Crossing Kynsey Road, a clinical society podcast, features conversations between doctors and medical students. Views expressed are personal and do not represent affiliated institutions. Content is for educational and entertainment purposes only and does not constitute medical advice, diagnosis, or treatment. Cases discussed are fictional and any resemblance to real people or events is purely coincidental. The speakers have no financial or other conflicts of interest to disclose.
Hello and welcome to the second episode of Crossing Kynsey Road, a clinical society podcast. So in the previous episode, we discussed acute coronary syndrome, how it is diagnosed, how it is managed, and also the follow-up treatment. And today we have quite an interesting topic, not from medicine, but from obstetrics and gynecology. I'm Abhirthan Rajendran and I will be your host for today. And joining us today is our guest, Professor Prabodhana Ranavira from the Department of Obstetrics and Gynecology. He had an illustrious journey since medical school, graduating with 5 distinctions and 6 gold medals. And having completed his postgraduate training, he joined the faculty in 2016. And also, along with his postgraduate, he has completed a diploma in benign gynecological endoscopic surgery from France. And he is also a fellow of the Royal College of Obstetricians and Gynecologists. And his research interests include medical conditions complicating pregnancy such as heart disease and also minimal access surgery for gynecological conditions. So, welcome to the podcast, sir.
Thank you for inviting me. I'm very happy to be here.
So, the topic for today is actually hyperglycemia in pregnancy. So, as a fourth year medical student, I have completed a few gen and obs appointments, and during these appointments what we see is a whole horde of mothers coming in to get their blood sugar series done. And even the mothers who are coming in for labor, we see so many of them with hyperglycemia and gestational diabetes mellitus. So it's actually quite a prevalent condition we see in our country today. So what do you think of that, sir?
Yeah, correct, right. So hyperglycemia, because it's an umbrella statement, because we get 2 types of blood pressure, blood sugar problems in pregnancy. One who already have diabetes, well, type 1 or type 2. And the next step is actually who develop diabetes in pregnancy. We call gestational diabetes mellitus. And as a country, and being in the South Asia and also being Sri Lankans, we have a 16% chance of having gestational diabetes in pregnancy, and also our type 2 and type 1 diabetes prevalence is also increasing. And other reason is that a lot of women are delaying their pregnancies, and by the time they are getting pregnant, they are in that age group where the diabetes are getting more prevalent. So all these factors in combination, we have seen it's the commonest endocrine disorder that we see during pregnancy.
Yes, so far we know that there are 2 types mainly, that is the pre-existing diabetes and gestational. So if you were to talk about the physiological changes, say in pregnancy, how does the physiology change in such a way that it predisposes the person to developing these conditions?
Right, so we have to look at the fetal perspective. So then, as the baby gets all the nutrition from the mother, and then when it comes to glucose, it's also from mother to baby, and it's through something called facilitated diffusion. So which means that it flows from high concentrate to low concentration. So the mother has to have higher glucose level so that the baby gets from higher to low. And also there is what we call a gated mechanism, or there is a pathway or a channel where you can't have unlimited glucose coming in, but quite a lot come, but there is a transport medium. So it goes through from high to low without wasting energy with the transport. So then at one point it gets saturated. So, but until such time the baby will get higher the glucose level, higher the glucose level the baby will get. So that's the basic principles to achieve that. So what the body does, or the placenta does, is from the day 1 of conception, it starts secreting what we call HPL, which is human placental lactogen, which is an anti-insulin hormone. And with that, it increases the glucose level. It's a diabetogenic, it increases glucose activity, and adrenal activity, all the diabetogenic hormones are becoming higher, and the HPL is the one which maintains from the day of conception up to 24 weeks it goes up, and from 24 weeks it plateaus and remain until they deliver. So then only the HPL levels of the mother goes down.
So it's mostly an endocrine issue. So
Yes.
these excess hormones that are secreted during pregnancy are the ones that predispose you to develop.
Yes, from the placenta.
So apart from these physiological changes, are there any other patient-based risk factors that predispose you?
Yes, so anything, because it's what we call the pregnancy is a insulin resistant condition. So any other condition already which makes somebody insulin resistant will predispose them more to develop diabetes in pregnancy, right? For instance, if somebody is high BMI, right, about 30, they are anyway insulin resistance is high. If somebody has polycystic ovarian syndrome, which is again insulin resistant, they are more predisposed to diabetes in pregnancy, and family history. And if somebody has developed diabetes in pregnancy before, they have 99% of developing diabetes in the subsequent pregnancies. And all this, any condition which increases their insulin resistance will predispose them to develop diabetes or hyperglycemia in pregnancy or gestational diabetes.
So would I be right in saying that there is some level of overlap between the risk factors for type 2 diabetes and GDM?
Definitely.
So now that we're talking about hypoglycemia in pregnancy, why are we so worried about it? Like, what are the complications in terms of the maternal side and also the fetal side?
Yeah, it's a good question, because now we all like to have, like long years ago when there was no diabetes in pregnancy, right? So people love to have chubby babies, like when a baby comes very scrawny, we are not happy. We want like some people to be very chubby, and like that's how we wanted it. So in long years ago in Australia, they did a study called Australian ECOIS, carbohydrate intolerance study in patients in pregnancy. So what did they did glucose test in pregnancy, which was not supposed to do. So the intervention group is actually to check for diabetes, and if they are diabetic, so they have two groups, one the patient one positive for diabetes and positive for diabetes, and one positive. The positive for diabetes were treated and the other group was not treated. The reason is that time we shouldn't check and treat. So we did that way. And they stopped the study halfway because they found that when you treat diabetes, their outcomes in many aspects were better when you have been diagnosed with diabetes and not treated. Now we can't ever do that study again, because it's now unethical to do a study like that, because now we know there's something called diabetes in pregnancy and we have to treat it. So that's the first time it happened, and after that, because now it's a diabetogenic period, and now we are calling pregnant women diabetes also. So there were a lot of research went on to find what is the level we should be checking, because it's anyway diabetic. So when are we going to call somebody diabetes? And also then how to treat diabetes, what are the complications of it. So then with time they found that there are maternal and fetal complications. And the maternal complications, they are like if they are diabetic, they are high risk for preeclampsia, hypertensive disorders in pregnancy, they have increased risk of cesarean sections and instrumental deliveries, they have increased risk of postpartum hemorrhage, and somebody who's diabetes in the same pre-existing diabetes, they have increased risk of miscarriages, they have increased risk of fetal anomalies, and as I told you, preterm labor, most of the complications associated with the pregnancies are seen at a higher rate when you have diabetes. And for the fetus, depends on whether it's the pre-existing diabetes or gestational diabetes. Now pre-existing diabetes, because there's macro and microvascular disease. If these are present, they have more tendency to become small babies, develop preeclampsia, and have preterm labors, intrauterine deaths, abruptions, and again placental diseases. Similarly, if it's developed diabetes later or not controlled properly, they have big babies, we call fetal macrosomia, and that increases the risk of cesarean section, intrauterine death, fetal trauma, and Erb's palsy, because they get a higher chance of having shoulder dystocias, and for the mother, perineal tears, third degree, fourth degree, so during labor. So those are the complications that can have what happened for fetus as well as the mother.
So quite an exhaustive list.
Yes.
Okay. So before we move on to GDM per se, I want to speak a bit about chronic diabetes or pre-existing diabetes. So for mothers with pre-existing diabetes, we do something called preconceptional counseling.
Yes.
So what do we do in this counseling session?
Right. So I always say this to, like, when I do any talk on any antenatal care. Right. So our the preconceptional counseling is unrated in Sri Lanka. Right. So now ideally nowadays in a society where we expect perfect, everything you go smoothly, to everything to be perfect, but sadly now the newer generations are having babies at a later stage, and all things, and people, the younger generations are having diabetes, high blood pressure at an early stage. All these problems are there, but still most of the Sri Lankans will what I call expected but unplanned pregnancies. Only in Sri Lanka that category is there. Other countries have unplanned pregnancies and what we call planned pregnancies. So they come, they will tell, I'm ready for a baby, and then we do a whole heap of tests depending on their history, and then we see whether somebody is suitable for pregnancy. And if they have a medical condition or any other condition, it needs optimization. We optimize. Let's say somebody is with diabetes, for example. So if the diabetes is not controlled, especially let's say we check the HbA1c more than 10. In another country, if somebody comes with more than 10, HbA1c more than 10 and pregnant, they will recommend termination because the baby has a higher risk of developing a congenital anomaly. Right? 8 to 10 offer termination, but try to control. Right? So here, if there's somebody that then we control the diabetes and give proper insulins, and sometimes some people are on newer insulin, newer drugs which may not be ideal for pregnancy, so we have to change them. And so the preconceptional counseling is something very important, regardless whether, even if you don't have any disease, before embarking on a pregnancy, it's mandatory that you go and see somebody, plan your pregnancy, and then do the relevant investigation, the routine ones, and depending on your history, some the pregnancy is contraindicated. Let's say for diabetes, somebody is having retinopathy, let's say kidney failure. So it's the pregnancy is contraindicated. So then we should offer them reliable, effective contraception. But sadly, a lot of people will offer them either natural methods or condoms, which has a 26% per year to fail, compared to a pill which is 1%, and compared to a intrauterine device which is 1 in 1,000 chance of failure. So, and we use something called medical eligibility criteria, and a small gadget where we check, and then we can decide, okay, this method is safe for the woman. So not all like just because somebody is having, those days when we were medical students, we were taught that if somebody is having medical diseases, condoms is only the condom is the only contraceptive available. All the others are contraindicated. And we give somebody who should not get pregnant a method which has a highest failure. So now we are different. So it's important that, so basically when you say preconception counseling, it's about assessing risks. If we found risks, whether we can optimize them, and until optimization, offer them reliable contraceptive method. And then start them on folic acid. And for somebody who's on diabetes, they're supposed to have 5 milligrams of folic acid. Sadly, in Sri Lanka, we don't have 5 milligram tablets, so we have to take either 5 tablets one go or 5 a day somehow. Right? So these are the things that we do.
Okay, sir. So, as far as the government sector is concerned in our country, do you think our preconceptional counseling services are underutilized?
Definitely, right? So even now, somebody is getting married these days, they go to something called the eligibility register, and from there they have a very a brief preconception counseling session done by the midwives in the MOH area. But there also people don't participate, right? So they are, and even the MOH can do if they go and talk. And now the government is encouraging to have a specific preconceptional counseling clinic in the MOH, so the people who are planning pregnancy and come get some advice. And even in Soisa, in our unit, we have what we call medical. If anybody wants to start a pregnancy with a referral comment and discuss about their pregnancy choices. So these are there, but as you said, it's very, very underutilized.
Okay, so we have spoken a bit about pre-existing diabetes, and now we move on to gestational diabetes mellitus. So when it comes to diagnosing or screening for GDM, sir, we talk about universal versus high-risk screening. Whereas in Sri Lanka, we do universal screening for all mothers, and in certain other Western countries, we go ahead with high-risk screening. Is there a specific reason for that?
Right. Okay. So now, what you need to understand is now we do universal screening at the booking visit. That's to check actually for pre-existing diabetes, and then universal screening for gestational diabetes happen all across the world. It's something that we do for all women, but as you said, in other countries, they do for what you call pre-existing diabetes, they do selective screening. So they have high risk factors. If the risk factors are positive only, they get the diagnostic test. For us, we do universal screening. Now that is because of a study done by one of our colleagues, Professor Katulanda. It is the first time in the world the whole country was systematically sampled, right? Or the representation. We usually say any study we do, like we always say there should be a further study. In our research, we always say that there should be further studies needed to generalize. But here is where the whole country was sampled. If you are doing something in that regard to Sri Lanka, there's no other study need to be done. So there they found that about 16% of women in the reproductive age group had either glucose intolerance or type 2 or type 1 diabetes. But the main issue was 35% did not know that they were having issues with glycemic control at the time of diagnosis. So it's high compared to other countries, and treating somebody or treating somebody with diabetes and the complications once it's too late is much more costly than doing universal screening. So that is the reason in our country that we do universal screening for all women who are pregnant at the booking. So once it's negative, like in any other country, we will do another screening test for gestational diabetes, which is after 24 weeks. That is because of after 24 weeks only the maximum of HPL. If you remember the physiology part we discussed. So from 24 weeks until delivery, the patient will remain with a higher HPL level. So if they are to develop diabetes, it's after 24 weeks. But from the beginning, it can happen. So in most cases in Sri Lanka, because they don't have preconception counseling, and when we check them at, let's say, 9 weeks, we get to know them that they are having problem with glucose, diabetes, and then we don't know whether it's pre-existing or gestation. So we call them hyperglycemic pregnancy unless we are sure that, or they are sure that they had diabetes before.
Okay, so I think you answered the next question I had also about the cost-benefit analysis of this screening. So moving on to the next question. So there are multiple guidelines when it comes to diagnosing GDM, and there are various cutoffs also. So could you elaborate a bit more on that?
Right, as I told you earlier, right, so now because pregnancy is anyway a diabetogenic period, and then there are so many, controversies when it comes to when to diagnose and how to diagnose diabetes. That is why, which is the most common endocrine disorder in pregnancy, have many guidelines. So nobody knows what to do exactly, right? So now in our unit in Colombo Crossing Kynsey Road, we have a very we have got a consensus on looking at evidence and other guidelines. So our unit management is slightly different, I would say, to a lot of other places, but there's a reason behind it. So we do universal screening for all, for the reason I told, and then we use oral glucose tolerance. It's actually screening plus diagnosis itself, but there are other methods like HbA1c, which is less than 5.6 is considered as normal. It's above that, they should go for OGTT because that's a screening test. fasting blood sugar. It's not so reliable because fasting blood sugar can drop during pregnancy anyway because baby takes glucose. And random blood sugars, PBBs have some benefits, but if it comes to a diagnosis, we use oral glucose tolerance test, and we use the 1976 WHO criteria, which is evident. They did a study in WHO in 1976 with several countries, and they came up with this cutoff for diabetes as if they are not pregnant. So the cutoffs are because in pregnancy, even, so later studies found out, even if somebody is having impaired glucose tolerance test, they also have a higher risk of getting either maternal or fetal complications associated with diabetes. Right? So most of now, even when somebody say HbA1c above 5.6, what it doesn't say the patient is having that, but it says there is a higher risk of developing either maternal or fetal complication associated with diabetes. So that's what it says. So then we do the OGTT. The values are, if the fasting blood sugar is more than 100, and if the 2-hour value is more than 140, is considered as impaired glucose tolerance, and 126 above or 200 after 2-hour value is considered frank diabetes. But in pregnancy, we call everything above 100 and 140 what we call hyperglycemia in pregnancy, unless they have been proven before to be diabetes. And when it comes to after 20, which are who are screen negative, who have had normal glucose tolerance tests or any screening test then done before 24 weeks, from 24 weeks until delivery, we use something called the HAPO criteria, which is a study which was done in 2000s somewhere, hyperglycemia adverse pregnancy outcome study, but the study didn't tell us about a cutoff. What they did was, the study was, they did the glucose test, but they actually test for 1 hour as well. But they used the WHO criteria, and so they have 2 groups now, diabetes group and non-diabetic group. And diabetic group they control and compare with the non-diabetic. So we can't do a study now, no treatment. But they found was very alarming, because even if somebody controlled diabetes properly, they did check every hour glucose levels, and until delivery, their study group was 24 to 32 weekers, because they want to control also, who were screen negative at the first. They found that even if you control diabetes, the diabetic related complication of maternal and fetal are seen at higher rate compared to non-diabetic. And worse the control, higher the risks. So that is where the study was done, but later they found those study and they did something called ROC, receive operator characteristic curve statistics, and they came up with this criteria. So they say if the fasting blood sugar is more than 92, 1 hour value is 180, and the 2 hour value is more than 153, is associated, the higher the level, are associated with increased risk of developing diabetes associated complication, either maternal or fetal. So HAPO doesn't say that you are diabetic or gestational, but we consider them to be gestational diabetes, and the criteria was different. So when it was introduced in that year, the WHO said we are not going to use those, because there were no South Asian in that study population, where the prevalence of diabetes is high. We are not going to change, but the original study had South Asians. Then came the DIPSI study, which is diabetes in pregnancy in India study, where Sri Lanka also part of Prof. Chandrika Vijayaratna was part of that study. So they did the study in Sri Lanka, and after the analysis they said we can also use the HAPO criteria, because when you use HAPO criteria, they found that more diabetes, and by controlling there's low incidence of diabetes related complications. So that is why we use DIPSI, or the HAPO criteria study, which is after 24 weeks until delivery. Even though the original study for 24 to 32 weeks, but physiology we know after 24 weeks they can be diabetes. So even a 36-year-old, 36-week coming for the first time, and we do the glucose tolerance test, we use the HAPO criteria. Anybody less than 24 weeks, we use the WHO criteria, which is fasting and 2-hour value. But in HAPO, there is fasting 1 hour and 2 hours. So this is what our unit uses. Because some other unit uses different criteria.
So something interesting you mentioned, sir, is that the glycemic control does not completely abolish the risk. So there is some other factor apart from the glucose level at play here.
Yeah, because it's not physiological. So we give medicine or insulin, but we will not be able to control it the way the body controls. So that is the reason, because we can't, like, unless there is a insulin delivering device, by like minute to minute kind of thing, what the body does in a natural way, we won't be able to mimic the control the body achieve in glycemic in a condition where there is a very delicate balance between hyperglycemia and normal glycemia in pregnancy stage.
Okay, sir. So, do we consider aspirin prophylaxis in some of these patients who have been diagnosed now?
Right. So chronic diabetes is considered as one of the high risk factors for developing preeclampsia. So, according to Aspirin trial, 150 milligrams of aspirin started from 12 weeks until delivery has shown to reduce this risk by 80%. Right? So, because of that, yes, that is pre-existing diabetes only, not gestational diabetes in previous pregnancy is not an indication for aspirin in pregnancy. However, there are the 6 major criteria, Sri Lankan criteria, and another 5 minor criteria to start aspirin, which is we should not be discussing clinical diabetes. Yeah, yes, but yes.
So, sir, in the long-term follow-up of these patients throughout their pregnancy, is there a place for fasting blood sugar and HbA1c? Because what we see being done in the wards is the blood sugar series for monitoring.
Right. So now, if you go back to physiology, now what is HbA1c? It's the percentage of red cells glycosylated. Right? Now, what we know is that in pregnancy, the RBC content or the RBC increased by 25%, and then the plasma increased by 50%. There's hemolysis. So there are, if you look at it, we say less than 7 or less than 6 for non-pregnant women, and the control is less than 7 is good. So that is percentage of cells. It's basically it's a saturation, or the how much of cells are glycosylated. So you have more cells to glycosylate, and they are diluted in more than 50. So HbA1c value is going to be low. At the moment, it's only validated up to 12 weeks. So up to 12 weeks, less than 5.6 is considered is normal. Above 5.6 is abnormal, where non-pregnant is 6.2, no, if I'm not mistaken. Yes.
Okay, sir. So that covers the diagnosis part of GDM. So moving on to the management. So once we have diagnosed the mother as having GDM, how are we going to manage them? That is pharmacological and non-pharmacological arms.
Right. So the good news is, if somebody is diagnosed with gestational diabetes, so I'm taking away all the chronic diabetes, because that's a more high-fi, more intensive control and management is needed. They need endocrine assessment, so many other factors. But we are talking about screen negative in the first trimester or the week 4, and now they have developed gestational diabetes. The good news is 80% of these women can be controlled only with medical nutrition therapy. When you say medical nutrition therapy, it's not dieting. The reason is, I'm being sexist now, you know how females diet. Right? So they don't eat in the morning, and they go to the office, and they sometimes divide the role into 4 and eat a little bit of peas and say, because they didn't have breakfast in the morning, and a little bit of cake, a little bit of sugar, a little bit of coffee. So they waste a lot, but they think that they are controlling, right? Or they control a few days and then they go back to their normal. So we don't say that. So we don't use the word dieting when we use food as a treatment. So what we are saying is medical nutrition therapy, or in Sinhalese we call it Poshana Vedi Pratikara Krama. So to give like little, this is not dieting. You have to eat like this, 10 string hoppers, 4 slices of bread, and and the bread has to be shown to the light and see, because some women will eat 4 slices, the whole loaf of bread. Cut in 4 pieces, it's 4 slices, right? And 10, the string hoppers, our diabetic education nursing officer will say you have to look at the light, and the light bulb should be seen through the string hopper, because otherwise it's too thick. So we go to that extent of control. It's like how much, 6 meals a day, how to eat, how much to eat, what not to eat, even the size of the fish or the chicken will be given. So that their control is absolute if they control it like that. Now compared to another country. So the other countries, they will ask to do control, and you can eat what we call low glycemic index food according to your diet, because let's say in England somebody will eat rice, somebody will eat chapati, somebody will eat some food that nobody has heard about, some will eat pizza, something like that, right? So in Sri Lanka, though we have ethnic differences, either is bread, rice, string hoppers or something, toast or something like that. So we all eat together.
Very carb
rich meals. So it's easy to manage, but so we kind of tell you, we have a device a method which has been begun. Now, ideal way is the medical nutritionist customizes. Let's say in our dietary there's what we call green gram. I hate green gram. So if somebody asks me to eat green gram, I won't be able to eat it. So ideally it has to customize according to how much glucose. But sadly, we don't have nutritionists to that extent to give that kind of services to all women, because it's very prevalent. So we have a very strict rule.
So under the non-pharmacological management, so we discussed diet. So is there a place for exercise as well in pregnancy?
Definitely. So exercise and to your tolerance, right? So in pregnancy, your cardiac output is anyway increased. So what we say is you do exercises, and when you are tired, you have to stop. Let's say you are not pregnant, you are doing 10 push-ups. After 8 you are struggling, you still do the next 2. But in pregnancy, at 8 you are tired, you stop. After 20 minutes, you do the next 2 also. So that will help you. So exercises, walking, all that will help to whatever the things that we do in non-pregnant state to reduce insulin resistance works.
Okay, so in terms of pharmacological management of GDM, how do we manage them?
Right. So there are, as you know, there are a lot of new drugs available to manage hyperglycemia and new insulin levels insulin drugs as well. But in pregnancy, any drug to be safe in pregnancy, it has to be in the market for 10 years or more. We call it post-marketing surveillance. Right? When if you remember the pharmacology, there are trials. We do trial, to check whether a drug is safe. Now we check any drug with what we call non-human pregnant. See, and then check whether there are any problems. But one of the lessons we learned from the earlier days was thalidomide. So we were started because it was gastritis, and a lot of women had it, and then had a massive, fetal anomalies for a whole generation. So because of that, nowadays we wait for 10 years. The only time we broke it in the recent past is the COVID vaccination. Right? So if a drug survives for 10 years without having complaints regarding fetal anomalies, then we consider that drug to be safe. So most of the new drugs have not passed that 10-year period yet. So we have only 2 drugs that we can use in pregnancy at the moment. It's metformin and glibenclamide. And as a country, we are more experienced in using metformin, because one reason it doesn't cause hypoglycemia compared to glibenclamide. So we can use up to 2,000 milligrams of metformin a day for pregnancy, apart from medical nutrition therapy when it's not controlled, which usually about another 10% will need medical nutrition therapy plus metformin.
So if we start them on metformin and there is still no control, we would obviously scale them up to insulin.
Yeah.
And in pregnancy, there are different types of regimens we use. Could you elaborate a bit more?
Yeah, right. So we use mainly 2 types, which we call basal bolus regime and the biphasic regime. So biphasic regime means we use mixed start. We use intermediate action and a short-acting used together, mixed in together, usually kind of a cream color. That's one of the things that we ask medical students, what color is mixed-art insulin, what color is soluble insulin and all that, just to check whether you guys have work in the wall, right? So now the advantage of having the biphasic regime is you get only 2 injections, morning and vesper. So like I have a needle phobia, so I would love that rather than getting 4 injections per day, which is the basal bolus regime, where they have a long acting and short actings to cover each meals and a long acting to cover the fasting blood sugar. Now we use these 2 regimes depending on now if somebody has medical nutrition therapy and metformin, but the control is not that great but not really bad, and the baby has no complications developed so far, especially macrosomia or what we call high A5 levels, polyhydramnios, then we can start with biphasic regime. So that and then we control and check the sugars and see if they are controlled, we continue that. But if the control is really bad and the baby has already developed or shows features of that the baby is affected by diabetes, baby is on the higher centile and the water levels are not polyhydral but getting higher and also close to delivery, then we have to go for basal palliative, which gives us more control.
So when we manage GDMs, are there any specific targets we look out for, or is it very individualized to the mother?
No, we have a very blanket targets, right? So we we do the blood sugar series, but now we try to do self-glucose monitoring rather than admitting them every fortnight to the hospital for the glucose control to see whether they have glucose control. So we have in our unit, we have if somebody is having either metformin, medical nutrition therapy and or metformin only, because we can't adjust the doses according to the meal value. So we do 4-point blood sugar series at home. That is fasting and 3 main meals from the start of the meal 2 hours later. That is post breakfast, post lunch and post dinner. If they are on insulin, we have to do 7-point, which is we do fasting, post breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner at 11 p.m. So 7-point what we call BSS, but we do now from a glucometer. So cutoff values for either is fasting. Now we, as a pregnant woman, you can't fast for every day for 10 hours. And we assume as a pregnant woman, you should sleep for 8 hours. So at least 8 hours fasting, 8 to 10 hours should be less than 95. And the 2-hour values should be less than 120. So we consider that to be, if they are within that range, we say they are good. And because our diet is strict, so we don't need to do them every day. In another country, they have to do that, and they have to do 7-point every day until delivery, and they are given the glucose meter and the strips free of charge. But sadly, the patient has to buy in Sri Lanka, glucometer and the strips. So because of that, we give either once a week or twice a week for point BSS or 7-point depending on insulin or other one, and assuming that they will control their other days with the same diet.
So we have seen diagnosis and also management of GDM up to now. So now we will move on to delivery of the baby. So one of the commonest questions we get asked about GDM is vaginal birth contraindicated?
Yeah, so before that answer, I just want to mention one thing, because some of the units will use 1 hour value, right? So if you look at it, that is 140. Now, when you look at the evidence, if you check the 1 hour value, it's a better predictor of fetal macrosomia compared to 2 hour. So then, why now the Professor Colombo bragging about our evidence-based practice in medicine, but then why are we using the 2 hour value? Now that is for a very practical reason. Right? So as I told you, So we cater for a population where sometimes they come from a very poor socioeconomic status, so they can't buy a glucometer. So they will admit every fortnight to the hospital. So why 2 hours? Because the what do you call, the visiting hours at 12. So the husband will come and feed the lady, and then they go home. And if we take at 1 hour, something very big happens at 1 p.m. in the hospital. That is change of shifts. So some nurses who have worked for 24 hours, 36 hours will change their shift at 1 o'clock, and they will have to do a handover, which is they are off at 1, but they will go around with the other nurses, handover nurses till about 1:30, and they go home. And imagine a patient coming and asking that my blood has to be taken at 1 p.m. It's not going to be practically possible. So we wait for 2 hours, which is at 2 p.m. So they have done their handover, and sometimes they have their lunch also, so they are happy and ready to take the blood. So we keep it even the people are doing at home, because now as a unit we are been using this 2-hour values from now. If you consider me being a medical student here, from my medical student it has been 2 hours. So and we are more, when somebody says 2 hours 120, or even without somebody saying the postpartum 120, we assume that it's 2 hours. So that's why we keep it, even though we know that it's not as good as the first hour, but it's only prediction for macrosomia only. But when it comes to control and other effects, both are same. So that's why we use 2 hours. This is a good example of adopting evidence-based practice to suit the local setting. So it's because evidence-based practice doesn't mean that just because the evidence says we can do it. So here we do a little changing because of practical situation. So to answer your questions, so now when it comes to delivery, it's first, as an obstetrician, I have 3 questions to answer when I see a pregnant woman. When am I going to deliver? How am I going to deliver? What am I going to do until then? So all this time we discuss about what are we going to do until then. So the time of delivery depends on patient's control, right? So we have a very very straightforward agreed protocol, which can be only broken by a consultant. That is, if somebody is either gestational diabetes or diabetes, hyperglycemia in pregnancy, control only with medical nutrition therapy, but no other complications, either fetal or maternal, we deliver between 40 and 41 weeks. Now usually our protocol for other women, they deliver 41 maximum. So here we tend to deliver them at 40 weeks. If they are on medical nutrition therapy plus metformin or insulin, but no other complications, fetal or maternal, we deliver between 38 to 39. If there are either fetal complication, maternal complication, poor control, anything is there, we deliver at 37 to 38 weeks or earlier, depending on how bad the complications are. So we have a plan. Unless a consultant will say, no, we can, okay, somebody's insulin on that, but we will wait till 40 weeks, the consultant will get. But for training purposes, because our unit is used by medical students a lot, so then they will not get confused. Right? So it's the time of delivery and the mode of delivery. Now, why are we delivering these women early? Why are we delivering now in a non-diabetic woman or a low-risk woman? We wait up to 41 weeks to deliver. The longer you wait, higher the chance of vaginal. In diabetes, it's the other way around. So the main reason to deliver babies early is, in diabetic women, if you wait longer, they have a higher risk of having a cesarean section. So by inducing them or delivering them early, we reduce the cesarean section. But compared to a non-diabetic, they always have a high risk of having a cesarean section. So to answer your question whether vaginal, it's not contraindicated, it's what we want. And as a diabetic woman, having a vaginal delivery is far better than having a cesarean section, because they have all the complications which are common after cesarean section seen at a higher rate, from wound infection to, right, at the time of delivery, the postpartum hemorrhage to infection to postpartum sepsis, all increases.
Okay, so that is complications rising from C-section in a
Yeah.
mother with GDN. So if we were to deliver this baby vaginally, what are the sort of complications we should look out for in the labor room?
Right. As I told you, so most will go for induction of labor because they will not go to spontaneous labor like the baby we want. Right? So then they need to be induced, and then you have to remember the babies can tend to be larger, and they have to have they may have increased level of water. So when you do induction of labor, there is a risk of cord problems. So you have to be very careful. We use something called controlled ARA. Right? There's a method to do that, so we don't release water quickly, so the cord doesn't. And also, even they didn't have it at that time, there's a risk of that happening later because the head may not be engaged the way we want it in diabetic women. So we have to be very careful in that. And also they can have hyperglycemic episode as well as hypoglycemic because pregnancy, the labor is a energy demanding state. So then also we restrict meals because they have a high risk of going for cesarean section. So we need fasting. So we allow usually clear fluid only for women who have an increased risk of having cesarean section during labor. So diabetes is also part of that protocol. For other women, we ask them to eat and drink during labor. Right? So here we restrict, but they can eat, drink fluids, and maybe have sometimes, depending on if they're very good control, maybe a sandwich also. But usually we clear fluids only. So then, and at the time of delivery, they have an increased risk of shoulder dystocia even for a normal size baby compared to a non-diabetic. 3.2 non-diabetic and the 3.2 diabetic may have a higher risk of shoulder because their shoulders are broader compared to a non-diabetic. So, and then trauma. So, what we call labor dystocia, where labor doesn't progress, there is malpresentation, malpositions, things can happen. So, that is, we have to be aware. And for the mother, there is increased risk of instrumental delivery, perineal tears, 3rd and 4th degree risk, and postpartum hemorrhage.
Okay, so is there any specific monitoring we do, sir, to catch these complications early?
Yes, right. So when the diabetic woman goes to the labor room, capillary blood sugars should be checked every hour. And in other countries, anybody with diabetes plus metformin or insulin, they should be going on the sliding scale of insulin. In our unit, we use only if somebody is having high, she's on a basal bolus regime with high insulin doses, only we use it. So we do check every hour CBS, and the side scale is we have insulin infusion going as well as dextrose infusion going. And then we balance it to achieve our target.
Okay, sir. So far we have progressed up to labor. So after labor, what is the natural course of the disease after labor? Like what happens? Does it resolve or?
Yeah. So what happens is, but because it's HPL driven, so when the placenta separates, the further increase in HPL should not happen. So we say the diabetes, gestational diabetes should cure after the delivery of the placenta. However, in practice, we see that because the HPL levels are still high, like whatever the release to the body, so it has a half-life. So until that half-life is achieved, we tend to monitor in the first few hours and maybe first few days, and then only we go for proper control. Right? So once they are discharged, we say you can eat and drink the way you want. Stop all your diabetes medicine or control, and then the final diagnosis of whether she actually had diabetes in pregnancy comes after 6 weeks of postpartum period, where I check their either fasting blood sugar, oral glucose tolerance test, or a random blood sugar. If it is within normal range, we consider that woman to have gestational diabetes. So it's a retrospective diagnosis at the end of the day.
So let's say, sir, this mother who has had GDN, we assume to have had GDN, is coming 6 weeks postpartum and the values are still above the cutoff. So what is our diagnosis then, and yeah.
Right. So yes. So then they can either fall into impaired glucose or frank diabetes, on depending that. So once the 6 weeks period, so we have to say bye to her. So it's our responsibility to go after that. 42 days is over. So we'll refer them to a physician for further management or the endocrinologist.
So it would be somewhat similar to type 2 management.
Yes. It's either impaired or what we call IGT or type 2 diabetes.
So are there any implications for the future, sir?
Yes. So if somebody is having gestational diabetes, they have more, as I told you earlier, 99% chance of getting diabetes in the subsequent pregnancy. And also they have a lifetime risk of more than 90% of developing type 2 diabetes in the future. Also their offspring are high risk of having metabolic diseases.
So I think that brings us to the end of this very interesting discussion on GDM. So are there any sort of take-home messages that you want to leave our listeners with?
Right. So as I told you, so diabetes is becoming more prevalent, and the risk factors for diabetes also increasing, and the age of having babies, first babies going up. So I can't emphasize the importance of preconception counseling. So something you have to be marketed and adhered nowadays in the modern society. So preconception is mandatory, and as long as you control your diabetes proper way, the complication of the diabetes will be less, even though we can't eliminate it. So it's important because the complication can be life-changing events for either mother or baby or for the whole family. So it's important because I always say in life, most of our things happen to us are uncontrolled. We have no control over it. But there is one thing under our control, which is sadly the one which has no control, which is your mouth. So control your mouth. That's the take-home message.
Okay, sir. Thank you so much for joining us today on this episode amidst your very busy schedule.
Yeah.
And a huge thank you to our listeners as well for tuning in for today's episode. And we hope to see you in episode number 3 of Crossing Kynsey Road. Thank you.
Thank you.